Yes, great. So, yes, I want to thank you, everybody, to be here in person, and as well, everybody that's online. I know that so many colleagues all over the world that are joining online this conference, and I really appreciate that. I'm going to start with a question then. So, studies on ceramic implants. What have been already done? Where are we now? And how do we want to assemble the future on ceramic implant studies? And I also want to invite you to join me in this journey that started quite a few months ago in the AO meeting, where a core scientific group did analyze studies on ceramic implants. And from 1,600 studies, 17 studies were selected and considered relevant. Relevant meaning that the methodology was patronized, the results could be done compared, and we have then reliable results. From this scenario on, you can see how many people, effort, brain, money, time was necessary to give us not that much relevant results. And nevertheless, what we have nowadays is a high top. Ich mag das nicht.
Okay.
A high-level technology for ceramic implants, where you can have full guided surgery. We can precisely decide which implant to use, and we have individualized treatment for our patients. We went really far, but we need to go further, or we will face the reality of titanium implant that is facing nowadays. If you just go through the PubMed, it's a page where you can search for scientific papers, and you just write down titanium dental implants and give you a try, you'll find out 23,000 studies on titanium implant. Easily, possibly, 1% relevant. And from those studies, no one could predict, preserve, or even stop peri-implantitis or corrosion that jeopardizes the future of titanium implantate today. We don't want to go the same path with ceramic implant studies. So what makes these 17 studies on ceramic implants so relevant? This, first of all, they were searching for success and survival rate. They used different methodologies. One-piece implant checking for clinical and radiographic outcomes, telling us how much bone is lost in a period of observation over 5 years, 2 years. We have studies that tell us when it's expected to see the most pronounced bone loss. We have studies that compare ceramic with natural teeth. We have studies that have as outcome the improvement on quality of life of our patients. We have studies that, of course, compare ceramic with titanium implants. And we can summarize these first studies as telling that ceramic implants have a very high survival rate. We are talking about 99% of survival rate. And relating to bone loss, when it's, what we normally see is that from the 6 months to 1 year after ceramic is in function, this is the very critical point for bone loss. But that doesn't go further than 0.82 millimeters, even after 5 years in function. Other studies that consider the time zero after the prosthetic restoration, that means the implant is already in function, and now you know if it's going to work, stability, and so more of those 17 studies comparing two-piece implants on posterior region with titanium implants, telling us about different kinds of restorations. We have also important studies that were checking about immediate loading and stability of this implant. We have that taking us into account the static as outcome, and we have also studies that could compare and give us very clear results what was going on with the implant and what was going on with the prosthetic restoration. Where was the failure going on? And we can again resume those studies telling that immediate loaded implant, zirconia implants, they are giving us a very safe results. And very important, patients report a permanent improvement on their function, on the aesthetics, on the sense, or on the speech, and that's very important. That means the quality of life of these patients is improving with ceramic implants. Okay, taking all this information together, what we can say is that we can strongly suggest that ceramic implant is an alternative for titanium implant, as it's safe as a biomaterial, but we are still lacking clinical evidence. And from those 17 studies, I did separate one study. This study started in 2013, pioneer, complete empiric, because the knowledge of ceramic implants at that time was an empty box. Nobody was talking about ceramic. And the two authors, so Dr. Neuhofer and Dr. Volz, decided to test the SDS implants, one piece and two piece, after immediate loading and immediate implantation, delay implantation, and delay or conventional loading. And for that, they separated 58 patients, which become 150 implants, upper kiefer, lower kiefer, as well as anterior and posterior region, and where 112 patients received the immediate, followed the immediate protocol, and 37 the delay protocol. And they compared that for circa 3 years, with parameters as margin bone loss, success and survival, as well as pink static score as an aesthetic outcome. Here you check how they measured the bone loss. They were using orthopantographs before the treatment and each follow constellation, comparing the margin bone loss according to Buzzer et al., which define the crestal bone as the most coronal bone portion that is still in contact with the implant, or BIC. This is exactly this point here. For the survival analysis, they did the classic Kaplan-Meier analysis, or survival analysis, and for the pink static score, they were scoring aesthetic using parameters like mesial papilla, color and texture of the soft tissue, contour of this restoration, and also alveolar recession. Let's go ahead and see what they found out. So the first graph, you can see the blue line represent for the period of observation, the result of immediate implantation. Immediate implantation gave us a success rate of circa 91%, and delay implantation circa 97%. Yes, 97%. Overall, in the success of this treatment with ceramic implants were 92%. The second picture shows us the bone loss. No matter if it was immediate implantation or delayed implantation, the bone loss did not show up higher amounts than 0.7 millimeters. And here, as an example, you see what means the pink static score as static outcome of your study. Once more, the different distance, six dentists apart from the study was receiving pictures like this before and for the follow-up consultations, and they once more evaluate the papilla, contour, alveolar recession, as well as soft tissue color and texture. And for this study, they have a result as 12.3, a score out of 14, which means a very high static outcome for this study. A work like this end up in only 1 point, a very good publication. This publication was published in January of this year, and BMC Oral Health. And when I look to a paper like this, what I really see on this paper is clinical evidence. Why? Because the authors were trying a immediate protocol, consistently done for 8 years, and compared with a control group, which is the delayed implantation or delayed protocol, with significant results, telling us that a treatment with ceramic implant, when following this protocol, works. This is clinical evidence, and that's what we miss nowadays in ceramic implant studies. I was so impressed with SDS implants that I decided to see what was going on in between 2013 and 2021. And I decided to check first how many implants were sold in this period, because SDS is considered a world market leader in ceramic implants. And I was a little bit curious about that, and my results are plotted here in this graph. You see 2 bars, a gray bar and a green bar and a gray bar. Green bar represents the 1.1 implant, it's the one-piece implant, and the gray bar, the 2.0 implant or the 2-piece implant. You can see a progressive sales rate along my study, and also from 2021 on, you see 2 other bars. That is the new generation, the bright, implant bright, which is the 1.2 red, and the 2.2 2-piece and 1-piece implant. These sales face the United States sales. The sales were always progressive, reaching a number of 122,000 implants. And you see also in my results 2 lines, 1 dotted line and 1 solid line. Those were failures and fractures that were happening along this period of observation. When I check the problems, well, okay, they are selling a lot, they are having very good results. What is going on with the problems with these implants? When I check about failures, failures mean you open wrongly the box or choose the wrong implant or fell on the floor, things like that. That represents no more since 2015 until 2022, no more than 6% of failure. And for the fractures, real fractures, these numbers for the 1.1 and for the 2.0 is around 1% of the sales rate. For the new generation, the bright implants, 1.2 and 2.2, this number is even lower, is 0.1% of our sales rate. And one conclusion, I was quite happy with what I was saying. Okay, every critical analysis that I make with a sample that sums 122,000 implants can really give me the information, what is success and what is failure. I'm positive about that. And I went a little bit further and wanted to see how much time it's expected to then, if you do have a problem, how much time it's going to show up a problem for me. And what you see in this graph, this is also a survival analysis, this is a Kaplan-Meier curve. You see on the top the immediate implantation protocol. You see on the bottom the delay implantation protocol. This first one is for one-piece implant, represented by for the red line, and the 2.0 two-piece implant, the blue line. No matter what protocol you use, doesn't matter also if it's one piece or two piece. If you do have a problem, you will have a problem around 3 or 4 years that this implant is in function. Then I was a little bit curious, not only analyzing the 122,000 implants, but also the 43,400 abutments that were sold in this moment, because I want to check in function. Okay, in function, then it's now with the prothetic restoration. Let's see how this behavior in relation to time to have a problem. And if you check this graph, I was analyzing upper Kiefer and lower Kiefer arch. And what I can see here is for the abutment, we will have a problem. If we have a problem, that will appear around 4 and 5 years after being in function. Then I conclude once more a thought. It's very nice to have results in ceramic implants 1 year, 2 years, but if you really want to face the reality of ceramic implants, you have to have outcomes for over 5 years, because we know that a problem will only happen, at least with SDS implants, after 5 years of being in function. So, and going further, I was still curious about the problems, and I decided to check, okay, when is happening problems with these implants? I found out 3 main reasons for a problem. During the insertion of this implant, because of biomechanical overload, and after prosthetic restoration. And I decided to plot in a graph also in relation to the expertise of the colleagues that were reporting these failures for us, or problems. And what you see is here in this graph. Immediately you can see that in between the 3 types of the causes of failure, a problem with ceramic implants, there was no significant difference. But the expertise of the dentist played a role. What does it mean? If you do have around 7 years of experience with ceramic implants, your risk of having a problem is around just less than 10%. But if you while you have 2 or 3 years of experience with ceramic implants, your risk is greater. Conclusion from this graph means we need to keep going and studying. We cannot stop. Continuing education is critical for ceramic implants success. And the second point is, clearly, that doesn't surprise me, you have a learning curve that is natural. You have a learning curve for ceramic implants that is around 3 years. You have to work. You have to keep going. You have to keep trying, because this is how you will expect to have minimal risk of problems with ceramic implants. And that all this together make us very motivated to set up during this Congress a consensus to decide together what is the next step for ceramic implants. Now, well, what should we look for? What should we test? And here in SDS, we started already 5 projects taking care of this future on ceramic studies. 4 of them happen now in collaboration with Frankfurt University, head by Professor Dr. Ganati. And one is being held here in-house. And what I want to share with you all is what we are discussing on the background of this Congress. So we want to set studies on the preclinical and the clinical level. And for the preclinical, we are especially looking for what is going on with the aging of the ceramic. In vitro, ex vivo, checking the wear, the erosion, what's going on when you drill your bone, what is coming out from this ceramic, what is the impact that for our tissues and our cells. Also other interfaces, as an example, the connection between abutment and or pillars or an implant. What is that in a long-term observation? What's coming out from this interface? We want to see the impact of that in fibroblasts in a cell level. We want to check that in vivo, considering animal work. Check the vascularity, hyperemia around the ceramic implant, compare with the titanium implant. Is there any change on this vascularity? We want to go and check about the debris. Is that a disruption of the soft tissue in long-term analysis or the peri-implant bone? Considering microtomography studies that we can, in small animals, analyze for a long time, live images of the behavior of a bone after an implantation. We are talking about a live animal, so I can really see what's going on in function every day, every hour if I do want. Okay? And human biopsy, as well as defining the bone implant contact in a histological level, because I don't want to have one measure here and Dr. Ganati, another one in Frankfurt. We need to have a consensus. We need to patronize these measurements. For the clinical trials, hopefully in 1 year plus, we are starting our clinical trials here in SWISS BIOHEALTH. For the prospective cases, retrospective cases, studies we are already running here in-house. Of course, always with randomized and controlled studies for a long-term analysis. We can publish 1 year results, no problem, 2 years, 3 years, but we are looking for more than 5 years analysis. We want to have the PAS as a consensus for aesthetic outcome. And very important for me, I would really like to set up a patronized PROM and a UHIP. That means patient-related outcome measurements. On the PROMs, you can analyze not only bone and tissue. I want to analyze this patient as a person. What is his function? What is his sociability after the implant? What his production in his work after having a new function in mouth? What is his relationship between his friends and families? Does anything changed? Socio-demographic data, this is very important. And the OHIP, that is oral health related quality of life questionnaire. That's a very important thing that I want to see. if ceramic implants improve or not the quality of life of my patients. Success in ceramic implants must consider quality of life of these patients. And I'm talking also about it because from this meeting, most of the specialists here will receive a questionnaire. And this questionnaire will have very precise questions that can engage all of us on predicting a very nice future for ceramic studies. And I would appreciate to have the feedback from you all from this questionnaire, okay? I stop from now, and I thank you all for your attention.